Once again, good evening and a very warm welcome to our webinar on knee osteoarthritis treatments. My name is Sharona and I'm hosting this evening's session. I'm delighted to be joined by our expert speaker, Mr. Matthew Oliver, consultant trauma and orthopedic surgeon. Tonight's session will begin with a presentation from Mr. Oliver, followed by a live Q&A. If you have questions at any point, please feel free to submit them using the Q&A icon at the bottom of your screen. You're welcome to ask anonymously or include your name. Just a quick note that the session is being recorded, so any names shared may be visible in the recording. To help us get through as many as possible, please keep your questions brief. If you're interested in booking a consultation, we'll share all the relevant contact details at the end of the session. And over to you.
Good evening, everyone. Thank you for the invitation to come to speak to you all via this webinar tonight. I'm going to talk to you about osteoarthritis of the knee, what it is and its treatment. So let's move on. A little bit about myself. My name is Mr. Matthew Oliver. I'm a consultant orthopaedic surgeon. I've been working here at Bendon since 2012. I trained in London at St George's in the late 90s. And did my higher surgical training in the southeast Thames region, mainly in Kent and Sussex. I've also spent a period of about 18 months in academic medicine, learning and studying the human knee joint, carrying out various basic science, clinical studies and bioengineering studies on different knee replacements. Following this, I went to Canada for a year and did a adult hip and knee reconstruction fellowship, working for six very eminent orthopedic surgeons, rotating in blocks of 4 months, working with them in pairs. It was a fantastic experience working in a different healthcare system. And I learned a lot, and quite a lot of the things I learned in Calgary I brought to my NHS and private practice and use the techniques to this day. I'm a hip and knee surgeon and got appointed to my local trust in East Kent in 2010. And I would consider myself a relatively high volume hip and knee surgeon. I perform 3 times the national average of hip and knee replacements compared to my peers. So included in this session, 7 sections. First, the consultation, followed by the problem, talking to you about osteoarthritis of the knee, then the treatment options, the risks of surgery, what the hospital stay is like, and the recovery following a knee replacement. And then we'll talk a little bit about what's available out there to help you make the right decision for whom and where you should have your knee replaced. And then we'll follow up with a question and answer session. So here's a picture of my colleague, Mr. Chipperfield, the medical director. He's examining a patient in clinic. It looks like he's assessing them for an anterior cruciate ligament injury. So basically, the consultation is all about making sure that we know what the problem is for a thorough medical history taking session, taking note of the symptoms and signs, followed by a full clinical examination, not only assessing the knee joint, but also the joint above and below the hip and the ankle. Along with that, the neurological function of the limb will be assessed, along with the blood supply or the vascularity of the limb. We sometimes require X-rays, and if we're fortunate enough, these will be available on the day. They would have been image linked across from wherever you've had them taken. But sometimes we have to send you off for an X-ray. And on a few occasions, more specialist images are required, such as MRI scans. And of course, we can't get these quite on the day just yet, but you'll have an appointment quite rapidly for one of these, and we should hopefully see you with the results within 2 to 4 weeks. Whilst we're assessing you, we're also triaging you for your fitness for anaesthetic. If you're going to have any operations here at Bendon, the most common anaesthetic technique, is to perform a spinal anaesthetic with sedation, certainly for the big ops like hips and knee replacements. Some of the smaller ops, such as a knee arthroscopy, are carried out under general anaesthetic. It's important that we assess your fitness for anaesthesia thoroughly, because we are a small hospital with not that much medical backup and in the countryside of Kent, so we have to be cautious about who is safe to proceed with an operation here. So what is osteoarthritis of the knee? It is essentially a disease process of wear and tear. It is incurable, and it presents very insidiously throughout our life. It gradually comes on us, and it normally presents initially with just a little bit of pain on activity. You might just get a bit of a twinge and a little bit of an ache where the joint is wearing out. So it may be on the medial side or the inside of your knee. It may be at the front of your knee if it's the kneecap that's wearing out. You'll also notice the knee feels a bit stiff, certainly first thing in the morning. As the problem progresses, your walking distance will gradually reduce, and you may notice it swell up a little bit from time to time. And eventually it will start to cause problems with your more enjoyable activities, such as playing golf, going for a walk, playing racket sports, etc. As the problem progresses, the pain, unfortunately, is there 24/7. Painkillers don't really help, and you'll have disturbed sleep at night. It will ache at the end of the day if you've been standing on your feet a lot, and also you may notice the shape of your knee changing. One of the things that you'll first notice is that you won't be able to fully extend the joint. That means lay it out flat on the bed. It will be a little bit bent in fixed flexion. You may also notice it becomes a bit knock-kneed or bow-legged as parts of the joint wear out faster than other parts. The causes of osteoarthritis of the knee can really be broken down into 3 or 4. Firstly, it's a condition that is idiopathic, in a sense that it's just part of getting older, unfortunately. All of us will have to go through that phase, and it begins in our 40s when the menisci, or the shock absorbers in the knee, start to degenerate and perish like washers on a tap. And they start to have little micro tears that all join together and form a larger tear, and therefore become ineffective with dealing with the shock between the joint surfaces. And when there's too much shock or too much load, the articular cartilage starts to break down. That's the actual cartilage that lines the joints. Initially, it shows up as little fissures or cracks, and then it breaks off in chunks, leaving bare areas of bone denuded of cartilage. When you get to that stage, which is in the latter parts of the disease process, it is almost like having bone on bone, and you can see that on a weight-bearing x-ray of the knee joint. Other causes of osteoarthritis are if you have you've been unfortunate enough to have had an injury to your knee in your youth, such as an ACL rupture, say for a skiing accident. It changes the biomechanics of how the knee works, and the knee becomes unstable and translates, rotates and flexes in a slightly wobbly way, putting extra load on the joint and therefore accelerating the wear and tear process. This can be to a certain extent reduced if you were to have the anterior cruciate ligament reconstructed, and there's strong evidence to show that that is a worthwhile procedure to have done if you wish to remain an active, sporty person and try to return your knee to near normal biomechanics. Other causes are a little bit more rare, such as avascular necrosis or SONC. That's known as spontaneous osteonecrosis of the knee. That's when the blood supply to the knee joint is temporarily damaged and doesn't always recover, and therefore the bone underneath the articular cartilage starts to break down, and therefore the cartilage has no scaffold to support it, and therefore collapses, breaks off, and acts as a nidus for the rest of the knee to wear out. probably the most important cause to mention in a webinar such as this is lifestyle issues, and that's obesity. Really, obesity is an absolute dead cert that you'll get an osteoarthritic knee. So lots of studies have proven this, and it's very closely correlated to what's known as your body mass index, which is a crude way of measuring your obesity. One of the figures that I've always remembered easily is the BMI of 40, which is classed as a morbidly obese. In the morbidly obese range, there's a 40% greater risk, or 40 times relative risk, that you'll end up having an arthritic knee. So 40-40 makes it easy for me to remember. So it's absolutely essential that you bring your weight down to put less load through the knee joint. So a healthy knee and an arthritic knee are seen in these pictures here. On my left, or the right of the screen, I think for you, is the healthy knee. You can see the two collateral ligaments either side, the cruciate ligaments in the middle overlapping, and healthy looking bone surfaces of the femur and the tibia. The menisci, or the shock absorbers, are not in this schematic diagram. And then on the other side, you can see the fissuring and breaking down of the articular cartilage and the red raw sort of bony areas. That's a very basic way of describing what happens in an arthritic knee. So the treatment options, non-surgical and surgical. The non-surgical ones are lifestyle advice, weight loss through using a dietitian, joining a Weight Watchers or Slimming World initiative, perhaps using weight loss injections if you qualify for these. And in some cases, patients have had bariatric surgery to bring their weight down, ready to have knee replacements. Activity modifications certainly do work, but a lot of people find that difficult to understand, that they should still do exercise and push their arthritic knee. There's lots of evidence to show that if you do light load-bearing exercise with an arthritic knee, yes, it will hurt, especially initially, but because you're building up the muscles around the knee, your knee will be more stable, and it will be very grateful to you for doing this, because it's the instability in the knee and the jarring of the worn out surfaces that contribute a lot to your pain. So building up the muscles around the knee, absolutely essential. And light load bearing exercise also helps the nutrition of the knee. There's no blood supply to the menisci and to the articular cartilage. It relies solely on nutrition by diffusion from the synovial fluid. And if you don't move your knee, then these processes are not stimulated. Strapping and braces have a role, and the offloader braces, it can jack the joint out so the bones don't touch each other. These work for a while, but patients usually find them quite cumbersome and uncomfortable, and you can't always wear the clothing that you wish because they're quite bulky. Other non-surgical treatments include steroid injections. These are tried and tested. It's usually local anesthetic and a steroid mixed together. And these are carried out as an outpatient procedure in the clinic and will provide reasonable relief of discomfort for about 4 to 6 months. The more you have, though, the less effective they become. And also having a steroid injection will preclude you from having a knee replacement for about 6 months because of the heightened risk of infection. There's also Durolane supplement or viscose supplementation that is offered here at Benenden if you're a member. This is having a Castrol GTX type injection of hyaluronic acid. Basically, hyaluronic acid is a key component of your joints, but as we get older, the concentration of that acid declines. And that acid has a key role in lubricating the knee joint. So the Durolane offers a sort of a super boost of hyaluronic acid, and again is quite effective for the mild to moderately arthritic knee for about 4 to 6 months, and it can be repeated. The other injection offered here at Benenden is called Arthrosamid, and I'll spend a bit of time talking about that in some detail in a few minutes' time. The surgical solutions, you can have an osteotomy. That means reshaping the knee joint. Not performed here at Benenden. It's quite a specialist procedure, and you have to catch the arthritic knee at a very early stage to make it worth your while. People that have these operations are normally in their late 20s, 30s, and maybe 40s when the arthritis is at a very early stage, and it's due to malalignment of the bones. So there's point loading of one particular spot in the knee, and the bones are reshaped to offload that area and distribute the weight more evenly. And you can have an osteotomy of the tibia or of the femur. It's quite a high morbidity operation, having your legs snapped and reset, and you need to be motivated and stick with it for several months while it all heals up. But it's certainly an option. Arthroscopic techniques, very few indications for keyhole surgery with an arthritic knee. There are a few exceptions, such as a loose body or a bit of bone floating around causing mechanical issues of locking and giving way. It can very much be beneficial to fish this out, and the patient's mechanical issues go away, and they're just left with the usual arthritic pain that they may be able to tolerate. Sometimes a meniscal tear in an arthritic knee is addressed through the keyhole, but we have to be very careful about this because there's no point debriding a meniscal tear for the sake of it. It has to be an unstable tear that's causing a mechanical issue. Otherwise, all we're going to do is speed up the demise of the knee by taking out the cartilage. Cartilage transplantation, not performed at Benenden, super specialist, been around for about 25, 30 years. And this is where they take non-weight bearing cartilage from the knee and transplant it into the worn out weight bearing area. The area that can be transplanted is very small. It's about 1 centimetre squared and maybe slightly bigger, and is normally reserved for very isolated patches of wear. The inclusion criteria to be selected for this is very tight indeed. And the fact that it's being practiced for 30 years informs you that it isn't quite 100% successful, but we're getting there. And certainly it is an option that is gaining momentum. This is joint preservation surgery to try and keep hold of your natural knee for as long as possible. And then moving on, we've got the different forms of knee replacement, the partial knee replacements, where you just have part of the knee removed and replaced, such as the medial compartment or the patellofemoral compartment, and then the total knee replacement, where all 3 compartments of the knee are replaced. Usually that's the patellofemoral and lateral and medial compartments. So Arthrosamid, this is a novel research injection. Hasn't quite got through all of the NHS, National Institute of Clinical Excellence approval hoops yet, but it's certainly tried and tested throughout Europe and is gaining momentum as a validated, reliable alternative to having invasive surgery. So what is it? It's a permanent implant that is injected into your knee. It's made of mostly water and a very clever chemical called polyacromide. It's non-biodegradable, so it's there forever. And it works by integrating itself into the synovial lining of your knee joint over a period of weeks to months. When it's doing that, it alters the function of the lining and stops it from making some of the inflammatory chemicals that irritate your knee. And also it makes the synovial tissue more elastic and therefore helps reduce the joint stiffness and reduces some pain and enhances function. It's really important to emphasize it is not a magic bullet. You will still have an osteoarthritic knee after this injection, and it will still gradually get worse. However, in many cases, it does seem to make living with an arthritic knee a lot more manageable for people. And there are several testimonials on the Benenden website to validate this. And in my own practice, I've had some quite miraculous reversals of where people have become a lot more active and participated in long walks, joined their rambling group again, got back to the golf course, and so on and so forth. There have been a few patients where their expectations haven't been met, and it is difficult to know for certain whether one will respond to this injection. The majority are responding, but there are percentages that aren't. And more, and on that note, it's interesting when people have bilateral injections. One knee might respond slightly more than the other. It's no rhyme or reason for that. It certainly seems to work well for knees that are mildly to moderately arthritic, and also where they have patellofemoral arthritis. Those people seem to benefit the most. That said, some people with quite advanced arthritis who are either too sick to have a knee replacement due to other comorbidities, or just don't want the hassle of a major operation, these people have opted to have this injection, and quite a few of them have come back being quite happy with some reduction in pain and better function. As I say, it takes a few weeks to work, up to 3 months, and in a few cases there have been a few late bloomers where it's actually taken 4 to 5 months to kick in. The manufacturers in their studies that they publish on their website have had results now up to about 4 to 5 years with maintained pain relief. We've only been using it here at Benenden for a couple of years, so we'll have to wait and see. It's a day case. It's carried out in the main operating theatre here at the moment. You come a few hours before the procedure to have antibiotics given orally by mouth. And when you come down to the operating theatre, your knee is cleaned with antiseptic, and then local anaesthetic is used to numb the injection site. While that's kicking in, an ultrasound is used to ensure that the needle is placed within the suprapatellar pouch, which is in the knee joint. If there is some fluid on the knee, then it is drained. If there's not, then 6 little 1 milliliter syringes are injected into the knee through the initial same needle used to administer the local anaesthetic. So essentially, it's just one needle prick. Once that's done, the needle is removed, a plaster is placed on the knee, and it's best to have a restful 24, 42, 48 hours or so, and avoid strenuous activity for a couple of weeks. There is a dedicated rehab program to follow as well, which is beneficial. The main risks of the injection are infection. That's why you have the antibiotics. And also you can have some increased stiffness in the knee for the first few weeks. And the final risk is that you don't respond. This is the graph showing you the 4 main studies that arfurosemide is currently enrolled in. The y-axis is the pain level, and the x-axis is the timeline. So at the top of the graph, that's the injection going in, and you can see over a period of 4 weeks the pain is coming down, and it reaches its zenith of effectivity around the 12 to 13 week mark. That dashed line is the threshold it needs to get past to make it clinically a viable solution, to use for this purpose. And then, as you can see in all of the studies, there is prolonged relief of discomfort for quite a long while. I've spoken about the Durolane already. That's the super booster of hyaluronic acid, and that reduces some pain for 4 to 6 months, and it can be repeated. There are no real nasty chemicals in this, but again, it's probably worth waiting about 4 to 6 months if you're going to have a knee replacement following this. And I've mentioned about local anaesthetics and steroid injections, and the only two important things are that you have to wait up to 6 months for your knee replacement. And if you have too many, it's actually counterproductive. It corrodes the cartilage. So knee replacement surgery, there's some stats there saying that over 100,000 were performed in the UK in 2023. I think it's about 140 odd thousand now are performed. I think that's the 2025 figures. And the average age is about 69. Most of the patients, just over 55%, most of them seem to be ladies. And the average body mass index is about 30.9 as well, which is in the overweight stroke obese category. 95% of the time, the main indication for the operation is osteoarthritis. The aims of the knee replacement are to reduce the pain and restore your function and mobility, and to realign the mechanical axis of the leg. If you've got a very bowed leg or a very knocked knee, it gives us an opportunity to straighten things out for you, which in itself improves your quality of life. At this hospital, since I've worked here, we've used the Vanguard knee replacement. My colleagues and I use this in our NHS practice as well. It's made by Zimmer Biomet, a large American orthopedic company with a good reputation on the whole. And the knee replacement itself it superseded the AGC knee, which was a very successful knee replacement made for 20 plus years. So this is the upgrade. It's been around itself for about 20 odd years now. And in that time, it's managed to become the highest rated knee replacement out there on the ODEP rating. And ODEP stands for Orthopedic Devices Evaluation Panel. It's an independent panel based in the UK that assesses all of the orthopedic devices that are implanted into the human body. And 15A means that it's got 15-year survivorship of greater than 95%. The 10-year survivorship figures of 96.4 must have been from a recent publication. It is usually cemented in place, and it can be performed with or without a patella resurfacing. There are three types of orthopedic knee surgeon. There's the person that resurfaces the patella every time. There's a selective resurfacer, only resurfaces if it's worn out. And then there's the surgeon that doesn't resurface the patella even though it's worn out. The Vanguard knee is a very forgiving knee replacement for the patella because of its very shallow groove on the top of that femoral component. I'm a selective patella resurfacer. I couldn't bring myself to resurface a kneecap if it was only very mildly worn or pristine, but I certainly would resurface it if there was more wear, especially if the patient is relatively young, because I know that in 10 years' time, that kneecap would have worn out and they would be back in pain again. So here's a video showing you what an arthritic knee looks like. You can see the ulceration of the cartilage on the medial femoral condyle. That's that red blob there. And then you can see what a knee replacement looks like. So essentially it's a resurfacing. It's not really a replacement in such. It's a resurfacing. The worn out bony ends are removed and resurfaced with pristine brand new ends that are cemented in place. And then a plastic bearing couple is connected between the two. And the knee is essentially balanced by your own natural ligaments. A little bit about unicompartmental knee replacements. These are performed at Benenden and have been for many years. This is a good operation if the osteoarthritis is mainly isolated to one spot, usually the medial side of the knee, or the inside part of the knee. It's quicker to recover from and less painful, and people say it has a more natural feel. And they are able to get back to probably more robust activities following one of these. the only caveat with this is that if you have any wear and tear elsewhere in the knee, that will come back and bite you on the nose at some point. If that arthritis takes hold, then the only way of getting rid of that and the pain is to have it revised to a total knee replacement. So thus the revision rates are slightly higher in the partial knee replacement compared to the total knee replacement. They are gaining momentum though. About 15% of the knees performed in this country now are unicompartmental knee replacements. But as I mentioned earlier, patient selection is absolutely paramount. Talking about the ROSA knee system, there's Mr. Chipperfield standing by the ROSA, which stands for Robotic Orthopedic Surgical Assistant. It's made by the company Zimmer Biomet. It's been around a good few years now, but what's great about it is that just like these modern cars, you can get software upgrades, and it's getting better and better. The main benefits really are the perceived reduction in potential pain that someone gets because it's less invasive. That usually leads to a slightly shorter length of stay in hospital, and there is a reduced risk of any soft tissue injury. It basically uses exactly the same instruments as a standard knee replacement, all the kits there as usual. The knee replacement itself is the standard one that I showed you in the video earlier that comes off the shelf. The robot doesn't do the operation like some people think. It helps the surgeon to plan the operation and then carries out the bony cuts to the plan and validates it at every step. The surgeon, though, has to make all of the important decisions along the way. It's also now possible to perform half or partial knee replacements using the ROSA. So here's a video showing you what the ROSA is all about and how it works.
ROSA Knee is a robotic surgical assistant for total knee replacement. Your surgeon is specially trained to use the robot. ROSA Knee does not operate on its own. Your surgeon is in the operating room the entire time and making decisions throughout your surgery. Your surgeon creates a plan for your surgery based on your unique anatomy. The robot helps to ensure the plan is executed as intended. ROSA Knee uses a camera and optical trackers to know where your leg is in space. If your leg moves, the robot can tell and adjusts accordingly. ROSA Knee provides your surgeon with data about your knee. This helps to personalize your surgery based on your unique anatomy.
So my own viewpoint on the ROSA Knee is that it's definitely an adjunct to improve the accuracy of performing a total knee replacement. At every stage of those bone cuts, we have to place the sensor back onto the bone cut and register it with the robot. And if we're slightly out, the robot will not let us proceed to the next step. We have to cut again until it's bang on. And when I say that, I mean it's within less than a millimetre or less than a degree. So it's very, very accurate indeed. It also gives the surgeon an opportunity to see what the potential knee replacement is going to be like before it's actually happened, to make sure that the sizes are correct, that the implants are positioned how he or she wishes them to be, and that the knee itself is stable throughout a range of motion. once we're happy with that, we execute the plan. As I said earlier, it's validated at every step. We put the trial knee replacement in, and then we run through another knee state evaluation with the robot to check that it matches the plan that we had earlier on. Sometimes we have to do a little bit of a tweak, such as a ligament release or remove a little bit of extra bone to free things up. But most of the time, it provides a very stable platform, and the knee feels very good and stable throughout a range of motion, which is what the patient needs to have, so they feel confident on the stairs, and they feel confident when they crouch or squat, and they don't have any feelings of instability if they turn a corner, and so on and so forth. I've experienced, because I'm about 51 years old now, so I've been around 16 years as a consultant. I trained before robots were on the scene, and I've experienced computer navigation, and I've then experienced patient-specific instrumentation, which is when CT or MRI scans are done of patients' knees and special molds have been made, and the plan is tweaked in advance to make before the mold is made, and then the bony cuts are made. And this is the next evolution on from that. And I don't think robots are going to go anywhere. I think they're going to get better and more accurate. We don't know what the long-term data is yet. There are a few medium-term studies out there comparing what robot knee replacements are like compared to conventional knee replacement. But one thing is for sure, it's important to have a high-volume knee surgeon who knows how to do a standard knee replacement, because it is still art and science combined. You know, you have to have a bit of a flair for it. It's about the feel and the look, and you just the sort of the innate ability of having done lots of knee replacements. It amazes me, you know, the little tweaks that you have to make, and that is through experience. And the robot doesn't have that empathy. It's a machine, whereas the human does. It's difficult to put into words, but it's a bit like a production line on with cars being made. All the cars are exactly the same, but if the knee, it's not. Everybody's knee is different, and you can't just put in knee A into patient B, or you know, it has to be custom made to that patient. And doing it the standard way or the robot way, that you'll always need that human touch. So the risks of joint replacement during surgery, you can injure the bone. That's very rare, but you can have a fracture. You can certainly get nerve injury, foot drop and numbness, but again, very rare. You can bleed and sometimes need a blood transfusion. There's a chance of a ligament or tendon injury, so we protect these with all the instruments. Afterwards, during the recovery phase, your leg will be very bruised, and that's something that people don't get warned about enough. Your leg will go black, blue, green, orange, all the colours of the rainbow, and the bruising can be quite dramatic, all the way from the little toe up to the base of your spine. It's made worse by the blood thinners that you'll put on to reduce the risk of deep vein thrombosis and pulmonary embolism. You will have a limp, and you will have stiffness and swelling for several months. It's absolutely crucial that you do your exercise. Otherwise, the knee will become a big clump of scar tissue and your result will be very poor. It is no pain, no gain. The first 6 to 8 weeks are hard graft. And it's important now more than ever that the focus is on prehabilitation to get you in the best fit state possible before you have your knee replaced. Then your recovery will be much swifter and more manageable. The late risks, implant failure, it does wear out. The knees start to play up a bit from about 15 years onwards, so it's important to keep an eye on patients at that point. You can have a late fracture. It can dislocate if you have a heavy fall. And also you can get an infection. The wound infection can be dealt with antibiotics usually, but a deep infection is a different kettle of fish. There's about a 1% chance of that happening. In a hospital like Benenden, it's probably less than 1%. It's very rare do we have infections here, fortunately, but it needs to be picked up early, and most of the time it can be salvaged with very strong antibiotics and having the knee washed out and the implants exchanged, the ones that can be exchanged, and that's usually the plastic lining. Your hospital stay, a couple of nights in hospital mostly these days, sometimes one night. You'll be able to walk on the same day as your operation as long as the spinal anaesthetic is worn off. You'll be uncomfortable and you'll have to do those exercises as mentioned. I don't think you'll be back to normality within 6 weeks like it says on that slide. I think that's a bit over realistic. I think it'll take more like 3 months, but certainly life gets back to relative normality by 3 months, and you should be driving your car by about 6 weeks. Mentioned about the bruising and the importance of the exercises in the first 6 weeks. You'll also come up for a follow-up with us where we'll check the wound, your range of motion and the x-ray. If you're not getting enough bend in your knee, we'll read you the riot act, and sometimes you might need to have a manipulation under anaesthesia if the bend is very poor. These are my colleagues. We all perform high volumes of hip and knee replacements. We've all worked together for many years. The patient support tools, Private Healthcare Information Network, or PHIN, that's been around for about 5-6 years now. It's getting quite a lot of data. Not many people in the public domain know about it, but search it up. You can look me up and my colleagues. You'll see where we work, what our volumes of work are like, and you can also see validated feedback. We have to get at least 30 feedback reports submitted before they will publish the results, but they're on there. National Joint Registry, the surgeon's profile. Again, you can Google us and hunt us down on there, and you can see where we work, how much operating we do, and the only other useful info on there is the mortality rate. But is that useful? Because it's an elective procedure and the mortality rate is hopefully going to be 0. Then you've got Doctify, the patient review platform. Benenden has endorsed this quite a lot over the last few years, and has gathered a lot of reviews. We've all signed up to it. It's validated, and it's a very useful tool. We can see how well we're doing, and it's nice to get feedback, good and bad, so we can tweak and improve our practice. The other one is Top Doctors, which is again very well used by patients when they're searching their surgeon. What you need to do, though, is really look for a high volume surgeon with good reviews, because they're the ones that usually provide the best outcomes. Some stats. Knee replacements are in the blue, 134,000 in 2024. I've mentioned the average ages already, and the BMI and the unicondylar knees, 15% of them. And you can see that most of the decision to operate is due to osteoarthritis. 98% of all knee replacements are performed on osteoarthritic knees. So here's the lowdown of all the prices, and I think there is a promotion running with this webinar. So we're moving on shortly to the question and answer session.
Yeah, thank you. Thank you, Mr. Oliver. Very informative. And I agree, it is vital for patients to do some research ahead of conversations. So we're really pleased to have so many of you with us today. And while we may not be able to answer all of your questions, we'll do our best to cover as many as we can. On this slide, you will find information on arranging treatment. There's our telephone number. And moving straight into questions, we have Prakash, who asks, can PRP, stem cell or arthrosamid injections help?
Certainly can. Arthrosamid is a proven treatment now for the arthritic knee. I've mentioned about that already. Stem cells, I don't have too much experience of those, but PRP is when someone has a sample of their blood taken and the blood is centrifuged, spun in a special machine, and all the goodness in the blood is kept and then injected in the knee, and it's supposed to stimulate and improve the lubrication of the joint. The one commercially available that I'm aware of is called N-Stride, made by Zimmer Biomet. I've never used it, so I can't really comment any further than that on that one.
Thank you. We have a question that is brought up from a conversation on BBC's This Morning, where research in Germany discovered injecting tiny particles into the knee appears to be successful with pain management. Does that lead into the question that you've just answered?
I am vaguely aware of that, but I don't know enough to be able to comment in detail. There are lots of novel experimentative things being done at the moment in arthritic joints to see if we can stimulate new cartilage to grow, and also to try and trick the knee into believing it's not arthritic. I'd have to go away and look into that before giving a more detailed answer.
Thank you. From Karen, we have a question that asks, can you have arthrosamid injections in both knees at the same time?
You can do, yes.
Can do, lovely. Patricia asks or advises that she's been told she'll be having a nickel-free knee replacement. Is the Vanguard the replacement that she will be having?
Yeah, so the Vanguard knee does come in a nickel-free form. Is called the niobium Vanguard knee. It's coated in this special metal alloy called niobium titanium. It looks very impressive. It's a gold implant, gold in colour. Yeah, so a nickel-free option is available. It's expensive, but if you've got a significant nickel allergy, it's probably worthwhile the investment having it done, so you know that all bases are covered. There was one question up there about arthrosamid technique. I think that's important to mention. There are the cases where arthrosamid technique is unsuitable. So there are some patients that you can't use arthrosamid for, and those patients that have inflammatory arthritis, that's rheumatoid arthritis mainly.
Right.
It's only licensed for osteoarthritis of the knee.
Okay.
And just the knee joint.
And that can be assessed during a patient's consultation.
Absolutely.
So Stephen posted a question earlier and has posted another one now. He wants to know, if you need both knees replaced, do you need to have them done one at a time or both at once?
They both can be done at once. It's a big hit for the human body. And a few patients have had bilateral knee replacements performed here at Benenden over the years. But you'd have to be medically A1 for that. They're usually younger people who have got really advanced arthritis, equally as bad in both knees. But the usual practice is to replace one and then do the other one within 6 months. And interestingly, it's important to do the other one quite quickly, because a few studies have shown that if there is a significant delay between the two, then the first knee replacement doesn't do so well, because it's having to work so much harder to compensate for the arthritic knee that's left behind.
Yeah.
So one after the other, safer way to do it.
That makes sense. Thank you. David asks, why is local or spinal anesthesia not appropriate for arthroscopy?
You can do spinal anaesthetic for arthroscopy, but it would mean that you would be laid up on your back for 4 hours or so afterwards. You would be numb from the waist down for hours afterwards. And normally it's done as a day case, and you hopefully be on your way home within a couple of hours of having the procedure, whereas with spinal, that wouldn't be the case. And it can be done under local anaesthetic. A few colleagues of mine over the years have done this. However, it is you have to have the injection significantly in advance. Local has to be infiltrated in the knee, so it just slows the list up, and there are not that many advantages.
Okay, thank you. Keith asks that his question is, if he has had a steroid injection, how long would he have to wait to have an arthrosamid injection?
That's about 4 months. Yeah, if it hasn't worked, the steroid, best to wait for 4 months, and then you can have an arthrosamid. They don't like it, the arthrosamid team, if you administer it too quickly after a steroid, because they're worried about a flare-up of infection and so on and so forth. It's only theoretical. It probably won't happen, but it's just a safety measure.
Right, thank you. Would you use arthrosamid in medial knee osteoarthritis?
Yeah, sure. Yeah.
Right. Lovely, thank you. Do you test for allergy to the replacement knee components? Would we test for that?
Not usually, but we do have allergy testing on site with the dermatologists here. They can test you for nickel. And over the years, I've had one patient who was allergic to plastic, and I had to get the polyethylene or plastic liner from the company, and she was given them to tape to her leg and to put in her mouth and to hold, and she didn't react to it at all.
Okay.
But they'd never heard of that in all of the years that they've been making knee replacements. So that was quite an interesting case. She was definitely allergic to plastic, though, because a plastic glass bottle would make her lips all blister.
Goodness.
But not the polyethylene that was used to make the liner, fortunately.
Lovely. Okay. Anna asks about collagen injection and supplements. Would that have any benefit in knee pain?
There's no strong scientific evidence about collagen supplements and joint pain. However, anecdotally, it does seem to help, but there's no real science behind it. Whether it's placebo effect or not is difficult to tell. I don't think it will do you any harm.
Prakesh asks, how many arthrosamid injections can you have, or time between the first one being taken? So how many can you have, and then how long would you need to have between procedures?
There have been a few cases of top-up injections that I've been made aware of with colleagues here, because we've been doing it for a couple of years now. But usually, I don't think it should be necessary. If you haven't responded, there's no point having another one. And if you have responded, hopefully it will last for quite a while. However, the company says there's no harm in having a top-up if you want to have one. Certainly no point having it if you haven't responded, though.
Yes. A very interesting question at the top is, can you kneel after a total knee replacement?
You can kneel. It's not very comfortable, and you should only kneel if absolutely necessary and pad the floor out. It's because you're putting all your weight through your kneecap onto your metal femur. So it'd be quite uncomfortable.
It's not going to be very comfortable, is it? Christine has severe osteoarthritis in her shoulder. Would arthroscopic surgery be a benefit?
Probably not, no. And I think what she means probably is arthrosamid rather than arthroscopic, I expect. It's not licensed for any other joint at the moment other than the knee joint. An arthroscopy in severe arthritis won't help either.
Yeah. Thank you. Do you know about a Misha operation? This patient or attendee, Lynn, understands that it puts a pad between the bones of the knee joint.
I have never heard of it, actually. No.
Thank you, Lynn. Thank you. This person has been given exercises to do. Will doing these stop that person from needing injections or replacement surgery? And is it okay to return to running or jogging a 5K distance circa 3 times a week?
Depends on the degree of wear and tear you have in your knees. But yeah, doing the exercises is a great way of keeping the muscles strong and the joints lubricated and with the appropriate nutrition. And it might indeed hold off the need for injections or replacement surgery. With regard to running, if your knees are quite arthritic and you've always ran 5K 3 times a week and your knees can handle it, then fair enough. But repetitive road running it's probably not the best thing to do.
Yeah. It's quite jarring, isn't it? Another question from Stephen Whiteley, who asked earlier about the functionality of full versus partial knee replacement and the ability to resume sport. Are you able to comment on that at all?
Yeah, for sure. Partial knee replacement is a bit of a more of a natural feeling knee, and people do get back to most sports, including skiing, running, racket sports, cycling, golf, and so on. That said, so do people with full knee replacements. But with full knee replacements, it is a little bit more restricted with regard to the functionality. It's harder to kneel down and to squat, and also you usually can only get back to doubles tennis or doubles badminton. There's people that can ski with knee replacements, and cycle. Yeah.
Thank you. So that answers Stephen's initial question quite clearly, because he wanted to know about getting back to racket sport and skiing. And then our final question for the moment is from Graham, who would like to know whether you are awake during the operation.
You can be. You can be completely awake, chatting away to the anaesthetist, or you can be halfway, or you can be completely asleep. It's under sedation and it's turned up or down as per the patient's preference.
Okay.
Yeah.
Lovely. Thank you, Mr. Oliver. Thank you. And thank you all for your questions and for being a part of this evening's session. If we have not covered your question and you have provided your name, we'll follow up with you via email. Can we move to the final slide? Thank you. As a thank you for attending this evening's session with us, we're pleased to offer 50% off the value of your consultation. A callback from your dedicated private patient advisor, an email with a recording of this session, treatment information, and loyalty rewards points, as well as updates on future events and health news. We'd really appreciate it if you could take a moment to complete the survey at the end of the session, as this will help us improve and tailor future webinars to your needs. If you'd like to speak to someone to book a consultation, our private patient team is on hand and available until 8 p.m. this evening, and from 8 a.m. until 6 p.m. Monday to Friday. You'll find the contact number for our team on your screen. We also have upcoming webinars on a range of topics, including Arthrosamid, tummy tuck surgery, diabetes, and urology, and these can be booked on our website. Finally, a thank you from all of us here at Bennington Hospital for joining us. We hope to hear from you soon. Take care.
Thank you very much. Good
Goodbye.
evening.